now go into a very, very important part of our treatment armamentarium. So this is intravitreal injections. As you know, intravitreal injections have actually taken, it is the number of procedures have far surpassed every other procedure which is there. So intravitreal injections is a very, very important part and parcel of every ophthalmologist. It is not just now confined into retinal specialists. It's for everybody that intravitreal injections are there. So how we should be best using the intravitreal is what we are going to look at in the next 90 minutes. So first of all, why is this called personalization? What happens is there is a lot of genetic variability between people, and some people respond well, some people do not respond well. So the pharmacokinetic, pharmacodynamic genetic variability between people to each drug is different, and we are coming to know more and more about it as we move on with more experience. We have certain biomarkers which will enable us, which will help us define which injection to give in which situation. So again, a person, like in modern medicine, unlike a lot of other things, it is like, if the patient comes with a single disease, we all treat it uniformly. But we are basically trying to tell you that you require a bit of personalization for that. The other factor which would be a cytokine based, which is going to come in. From the tears itself, you can pick up a lot of cytokines, which tell us, which drug you should be using. There are other needs like short-term needs or even long-term needs. Some people require injections once in 6 months. They cannot come very fast. There are some people who have MI or thromboembolic risk, etc. So considering all this, we have to individualize and personalize the treatment. And over the next few minutes, Dr. Manab Jyoti Burman, who is a retinal specialist in Sri Shankar Deva Netralaya, Guwahati, will speak to us on the need for personalization and an overview of that, and then we will go into that one by one. Over to you, Manab. Can you come? You can connect this. Okay. Let's go here later. Yeah, it's not coming here. Yeah, good morning everybody. Thank you, Dr. Gopal, for giving me the opportunity to be part of this IC as well as the AIOC. Actually, the AIOC for just giving me this opportunity. So, next few minutes I'll speak on the individualization and personalizing injections in the eye, the next big revolution in medical retina. So, I don't have any financial disclosure to make. So, retinal disease is a leading cause of severe vision loss. That is all we know. So, I'm not going to the details of statistics. So we have a number of anti-VEGF injections as well as steroids and number of delivery systems in our armamentarium to treat the different type of retinal conditions. So all these, the anti-VEGF, though they are in the anti-VEGF, they have different pharmacokinetics and pharmacodynamics as well as there are different responses of treatment we see, and that is why we will have to select which anti-VEGF to be given for which patient, and we often see some kind of misuse of this anti-VEGFs in certain situations. So anti-VEGF therapy, though it is claimed to be quite promising in different studies, but in real world scenario we see not that kind of outcome because of delay in diagnosis and progressive courses and some unpredictability of recurrence and long-term management needed for these type of cases. So how to improve outcomes? The solution is the individualization and personalization of the treatment. So how to individualize then? Number one, your clinical experience. Number two, innovative diagnostic modalities and their correlation. And number three is the deep learning.
So innovative diagnostics modalities, the biomarkers, a number of biomarkers have been designed in terms of OCT, as well as angiography, as well as systemic biomarkers to define and quantify disease severity and guide treatment decisions. And these are very, very important while deciding for treatment with anti-VEGF. ARDS2 has shown the sensitivity and specificity of OCT biomarkers. So OCTA allows non-invasive high-resolution imaging of retinal and choroidal vascular cell. It is highly reproducible as well as a very simple procedure if it is available in your setup. So this is just a simple case of hemorrhagic PED. You can see there is a is there a pointer? You can see a lacy pattern of neovascularization here. Yeah, lacy pattern of neovascularization here, and this is a post-treatment finding. You can see the change in the neovascularization membrane. So this is how this is how OCTA helps in follow-up of the cases also. So this is another case. You can see the primary physician treating it as a CSR case, and when an NGOCT was done, you can see a lacy pattern of the CNBM here, and it was treated with 3 doses of anti-VEGF, and you can see the change in the pattern of the neovascularization as a resolution of the fluid. So imaging biomarkers, what it? They help in subclinical diagnosis. So many of the cases, clinically, we see very less number of findings, but while you're going through the biomarkers, we can diagnose the cases. Often it does not, but correlate with BCVG also. And this suggests a multitude of different disease origins. So what is an ideal treatment regimen? Maximum and maintain visual acuity benefits. Decide when to treat rather than whether to treat now. So on every visit we should plan for the next treatment protocol and titrate the treatment intervals to match patient's needs. So while comparing the treat and extend protocol with VRN protocol, you can see that multiple studies has proved that treat and extend is a superior treatment protocol in terms of this CNVM and diabetic maculopathy also. So treat and extend is a proactive and more personalized approach to reduction in associated treatment burden and better utilization of resources. But it may be sometimes difficult for high patient load situations like in India. So there are while there are cases of some optimum responders, there are some poor or non-responders also. Then what is the cause of this poor or non-response? Most important cause is a suboptimal dosing. Disease already at an advanced stage. There are multiple cellular mechanisms in lesion types and genetic variations, as Dr. Pila has mentioned, and potential tachyphylaxis also is a factor, and poor access to clinical or delayed appointment in our situation. Now this is the non-clinical condition. And how to maximize the outcome? Re-evaluation of diagnosis, if necessary, switch to alternative therapies. So we'll have to know when and how to switch to alternative therapies. So there are certain cases we can discuss in the next half. So I'll just quickly go through the cases. This is a case of IPCV. If you see, there is a nice hemorrhagic PED and this aneurysm here, and so this was treated with anti-VEGF aflibercept, and ultimately the membrane was regressed, but the PED was persistent, and this polyp was also there. So ultimately a focal laser was done to the polyp, and you can see the difference, the resolution of the PED here after the focal laser. So this you can see the difference of the polyp after the focal laser. So many a times we just keep on giving injections, but sometimes we need to switch up to other alternative treatment also. So this is another case. You can see this is a CNVM here, subretinal. So ranibizumab was given to the patient, but it was progressing. You can see after first injection it was progressing, second injection it was also progressing, and after third injection you can see the changes here. So at this point we changed the anti-VEGF to aflibercept, and after aflibercept we can see 3 doses of aflibercept, we can see there is a resolution of the membrane. So, but whether at this point did aflibercept work? So this is again a question. So after 2 months again the patient came with again the recurrence of the PED with SRF, and again aflibercept was given, but along with PDT, and ultimately you can see the membrane was gone. So how we should know how to switch off and how to aid other treatment. So this is a young diabetic lady with you can see lots of hard exudates at the macula, sudden deterioration of vision with hemorrhage at the macula. So it was at the last trimester of pregnancy, so we cannot go for anti-VEGF theoretically. So we decided to go for PRP as well as dexamethasone implant. So you can see after a single dexamethasone implant, there is a resolution of, along with PRP, there is a resolution of the retinal findings. And ultimately, after the delivery, we switch up to anti-VEGF, and after 2 years of follow-up, you can see the retina was quite good looking, but there was the development of cataract in the eye, and so cataract surgery was done, and this is the whole scenario of the patient, you can see. This is not moving slides.
Okay, Manab, I think the point well made.
Yeah.
A lot of biomarkers,
Yeah.
and the newer, AI is a very new thing which
Yeah,
you are going to speak about, I know,
that
because deep learning gets you
Yeah.
a lot of information as to how each person may respond, right?
Yeah, so the three components of the
Yeah.
artificial intelligence, like artificial intelligence, machine learning, and deep learning. So we should know the deep, because these are the new things to be added to our treatment protocols in recent years.
Yeah.
So thank you very much.
Yeah. Thank you very much for providing us with an overview of personalizing treatment. Now let us go into biomarkers in a little more detail. For that, I would invite Dr. Darius Shroff, a dashing vitreoretinal surgeon from Delhi.
Thank you.
Everybody, thank you for that kind introduction. So now that we have an overview, I'll be speaking on imaging biomarkers which help, because the main aim of this course is to target and tailor and personalized retina therapy. So I'd like to thank Dr. Neha Goel and for her help also with this presentation. So when we go through this very crowded table, you can see the imaging focus basically relies on things like fluid, the retinal layers, vasculature, and the CNVM. So if you see all these, the common factor is the OCT scan, which is very vital for us to look for any of these biomarkers. It's important that we kind of standardize the anatomical landmarks to be able to read a OCT scan well. And this consensus group which published in ophthalmology in 2014, this paper is excellent. So anybody interested in image, I would recommend you read this. And this helps us to see the OCT layer by layer, decipher the layers. And only if we know the normal structure are we able to identify these important biomarkers. Why do we need them? There is no reliable method which determines which individuals will gain or lose vision over time. So these predictive biomarkers become a major unmet need when we see patients in our OPD. These would help to enhance patient counseling, because as retina specialists, we know it's very, very important to counsel patients correctly if we want them to comply with our therapy, injection, to accept their vision, etc., and improve risk stratification. Possible visual acuity surrogates have been the ELM integrity, the EZ integrity, and the presence of subretinal fluid. I think all of these are going to be discussed by later speakers in detail, so I'll just discuss a few of them and the more important ones. So drill. So drill was one of the markers published first by Dr. Jennifer Sun in 2014, and this is very important. You can see that the image itself is quite clear where the drill is present, and where you can see the inner layers clearly and it's absent. And the horizontal extent in micron is what we have to calculate. Drill is assessed independently and not graded differently in the presence of CME, intraretinal CIS, ERM, SRF, or any other OCD evident pathology. So it's totally independent to these. So that's important to know. And here you can see these animations and the area marked with drill, and that can be calculated. So the association of drill extent with vision was more consistent and robust than any other SD-OCT biomarker. And in the central 1 mm area, they said a drill increase of 300 micron from baseline 4 months reduced the vision by 1 line compared to the baseline. So the relevance is that drill seems to be correlative predictor biomarker that is independent of the central retinal thickness in eyes with a basal center involving DME. Unanswered question about it is whether the visual acuity potential declines with increasing drill location. So this is something we still don't know. Now we come to these so the hyperreflective spots, dots, hyperreflective foci, all these terms have been used interchangeably. So what is it? It's a foci which is less than 30 micron. The reflectivity is more than the RP band, and what is interesting to see, you can see on the scan that there's no back shadow caused by this. So there's no visible hard exudate in that location. It's focal and discrete. Is it disease specific? No, you can see this long list of retinal diseases in which we can see these HRF, and it can be anywhere. It can be from the inner retina to outer retina in DR, and it's supposed to travel from the outer retina to inner retina in AMD. Why does it happen? Because of the blood retinal barrier breakdown. Some people say it's because it's a precursor to hard exudates. Others say they're degenerative photoreceptors, or it could be macrophages which have engulfed the degenerative photoreceptors. The other theory is because it's a cause because of pigment migration, but nobody has ever proved that these are cell. So the presence of these in the outer retina is closely associated with disrupted ELM and ISOS line. And this is what has been said to be the cause of the decrease in visual acuity in these patients. So is it machine dependent? So basically, other thing which people say when you talk about these biomarkers is that I have a machine, somebody has X, Y, Z different machine. So this was an interesting study by Dr. Ursula Erfurt's group from Vienna. And they found that although these focal hyperreflective deposits are seen on all them, but they're most impressively seen on the spectralis. So that's not to promote any machine, but we need to be mindful that if we are following patients from different clinics on different machines, everything may not be exactly the same. So this is the images from different machines, and you can see the difference in the number of dots. So it's an interesting finding. Whether it has a structural element of its own is not established, and the utility claimed seems to be far beyond than what is actually proven. When we come to CNVM, I'll just touch upon this very briefly because I think there's already a talk on this, but active CNV, Koska's group from France has said that at least 3 of the following features, the well-defined, the lacy or C-fan shaped network, the branching dense capillary network, the anastomotic loops, or the perilesional hypointense halo. So if any of these 3 are present, it's supposed to be active CNVM, whereas quiescent if less than 3 of these. But these don't have any predictive value to guide anti-VEGF therapy, so we are still dependent on our structural B scan to do that. So just an image where you can see the lacy network. So these are on the left side, you can see the active ones, whereas the filamentous one with the dead tree appearance are the inactive. I think ORT already was described, but outer retinal tubulication is something which we need to be very mindful of because this should not be misdiagnosed as CME, because CME, if we see CME, generally the tendency is to treat these patients. So these are round oval lesions with a hyperreflective lumen and hyperreflective border. And they are seen in advanced AMD, CNV, GA associated poor vision and photoreceptor loss. And even degenerative diseases, dystrophies like our retinitis pigmentosa, Stargardt's, etc. might have these and develop because of the photoreceptor disruption by invagination of the remaining cells and scrolling of the ELM. So it may be a response to preserve the photoreceptor survival, but they have poor prognosis, and this could be one indication to stop therapy in such patients. So with this, just a bird's eye view, I conclude that they help personalize of medical retina for our patients, and a tailored approach is best to treat our patients better. Thank you so much for the opportunity.
Thank you very much, Darius, for providing us with that overview. We'll go to a brief discussion regarding this before Dr. Natasha goes in. So, Darius, can you tell us, like, based on the pattern, let's first talk about diabetic macular edema. Based on the pattern on OCT, whether it is cystoid, spongy, or subfoveal detachment, would you consider changing your injections, etc.?
Yeah, so that's a good question. Actually, basically what we found is chronicity seems to be more associated with the large cystoid macular edema. So nowadays, these are the ones, of course, even there's a lot about the hyperrefractive dots along with those, but then those are the ones which, especially if they don't respond, we try to treat them with steroid. Of course, Dex implant or IVT, whatever, that is your choice. But these we would be more keen to change our treatment pattern to steroids. And otherwise, I think you have to take the whole gamut. There's no, like I said, a tailored approach, because some of these spongiform, maybe we do good FFA and you find some leak. So we still, I think focal laser has a role in those. So I think we should try to see the big picture also, and these are just things to help us.
I think we can't be talking about one particular biomarker and using it. I think that's a very, very valid point. You need to see the bigger picture. Dr. Dinesh Talwar, sir?
See, I think even today we don't have a biomarker for deciding treatment. The fact is that anti-VEGF agents are also anti-inflammatory agents. To say that steroids are anti-inflammatory and anti-VEGF agents are not is not true. Anti-VEGF agents are, they act on heparin, which is supposed to be 1,000 times more potent as an inflammatory marker than, than many other markers which you're using right now. So in that situation, the first issue is not whether A works better than B, but is it A safer than B? So if I have to take safety into account, my first drug of choice is always an anti-VEGF. And if it doesn't work, I always have the steroid to go to. And fortunately for me, actually a delay of say even 6 months, forget 3 months, I'm saying even 6 months, in starting off steroid does not affect the prognosis. We know from, and this is not personal experience, I'm telling you based on the evidence we have. The Rise and Ride study did not give any anti-VEGF for 2 years. The Restore study did not give for 1 year. In the Restore study, in 3 years, all the groups came to the same level. In Rise and Ride study, 2 years delay caused a loss of final outcomes. So if you delay 3 months, 6 months, is not going to change your overall prognosis. So you start with anti-VEGFs unless there's a contraindication to anti-VEGFs. And then once you've given that and not got a response, you can always shift to steroids. And you will not lose anything. That's the important thing.
Yeah, I think, especially in diabetics, that urgency is not there. In fact, we start first stepwise to first with good metabolic control.
Yes.
And then the next step may be anti-VEGF. That is taken care of.
Yes.
Yeah, of course. Thank you.
Okay, any other questions regarding this overview of biomarkers? Otherwise, we'll move to the next talk. Any other questions? No. Okay. So Dr. Natasha Radhakrishnan will be speaking to us about all the arrows in our quiver. So what are the injections that we are talking about, and what are we armed with?
A very good morning to you all, and I thank Dr. Gopal for giving me this opportunity. So let us see what we have to attack all these diseases with in the retina. So anti-VEGF therapy is one of the greatest achievements we've had in the last decade. So a little bit of history. In 1948, Michelson hypothesized that there was a diffusible hypoxia-induced angiogenic factor that was responsible for neovascularization, and that was identified as VEGF in 1994. And we got the first anti-angiogenic therapy for ocular neovascularization as the pegaptanib. And after that started the off-label use of bevacizumab, then came ranibizumab, aflibercept, and then the latest brolucizumab. So what are these? The pegaptanib was an aptamer, while bevacizumab is a monoclonal antibody that binds to all VEGF-A isoforms. The ranibizumab is actually an antibody fragment, and again it binds all VEGF-A isoforms, and aflibercept is a fusion protein. This is showing in a little bit more detail the molecular structure of all these anti-VEGF agents, and you can see that each one is actually a different entity and not the same. Oh, just a quick, I'm just telling the names because these are the studies that gave us these drugs. The Vision trial gave us pegaptarib. Of course, it's no longer being used now. And the Marina and the Anchor study gave the FDA approval for the ranibizumab to be used in AMD. In venous occlusions, we had the Cruise and Bravo for use of ranibizumab. And the Altair study gave us aflibercept. Now, after that, we've had a horde of biosimilars. So these drugs are all biologics, which is a class of medication in which the active pharmaceutical ingredient comes from a living organism that cannot be synthesized by chemical means. On the other hand, your biosimilar, it has that is highly similar in safety, purity, and potency to the biologic. And we also have the brolucizumab, which is the latest arrow that we have in our quiver, and that is marketed as Paganax in our country and Beovu in other countries. Now this is a humanized single-chain antibody fragment that inhibits all isoforms of VEGF1. It is the smallest of the anti-VEGF antibodies, and it gives high molar dose and high concentration. If you look at that, it binds to VEGF-A in a 2:1 ratio initially, but then a complete blockage of VEGF-A is maintained. And it's a low molecular weight, so it's about 4 times lower than aflibercept and 1.8 times lower than ranibizumab. So you get a 12-fold higher molar dose compared to aflibercept and 22-fold higher molar dose compared to ranibizumab. And it was the Hawk and the Harrier study that gave us this new molecule. I'm not going into the details of the results. So those are the anti-VEGF molecules that are available here. Bevacizumab, of course, is an off-label use, and though we have a horde of trials that have bevacizumab also in it. Then comes our next group of arrows, which is the steroids. So we know that not only VEGF plays a role there, there are a lot of pro-inflammatory molecules that cause these changes in the retina, and corticosteroids can act to downregulate these inflammatory molecules, and they also have some amount of anti-VEGF action as well, and that stabilizes the blood-retinal barrier. Triamcinolone has been the weapon we've had from a long time, and it's still a really, really effective drug, especially when a patient cannot afford anything else. The only problem with it was that we had a very high incidence of cataract and almost 40% incidence of intractable glaucoma. So the SCORE study was with triamcinolone in venous occlusions, and then we got our dexamethasone implant, which is through the MEAD study. That is the implantable dexamethasone that came to us, which gave us longer duration of action and lesser incidence of glaucoma, and most of the glaucoma was medically treatable. That was the Geneva study, gave us that for venous occlusions. And then those are the two implants that we currently have. We also have the fluocinolone, but it is not so commonly available. Then comes the last thing that we have, which is actually the first weapon we had, which is the lasers. Of course, you have a whole variety of lasers being used in ophthalmology, of which the argon and the double frequency Nd:ARG is what we use in the retinal photocoagulation. It was the old landmark trials, DRS and ET-DRS, that told us about pan-retinal photocoagulation for neovascularization and focal and grid laser for diabetic macular edema. Now, we needed a few newer concepts in the laser because of a lot of side effects that these lasers had. And some of the newer ones that we have are the Pascal laser, the pattern scanning laser that gives you a rapid array of multiple burns. And the advantages, of course, it is improved efficiency, increased safety with a central fixation spot and a foveal exclusion zone, and reduced pain and visual field defects. We also have the navigation guided laser, or the Navilas, which again you can set a pattern and then it shoots. Then we have the subthreshold micropulse laser for the macular photocoagulation, which is an 810 nanometer diode laser, and it reduces the laser damage to the adjacent ocular tissue, and it's very promising. A lot of use in diabetic macular edema. So this was the overview of all the arrows that we have in our quiver, and across the rest of the session we will see how each of this can be used to personalize treatment in retinal conditions. Thank you so much for your patient hearing.
Thank you very much, Dr. Natasha. So here we have an array of anti-vascular endothelial growth factor agents, anti-VEGF agents, which are primarily bevacizumab, ranibizumab, aflibercept, and the new one, brolucizumab. So just to say, Avastin or bevacizumab is the off-label drug, which is cheapest, but it has some reservations which are along with that. And then we have the ranibizumab and the aflibercept. And ranibizumab is a very standard drug which has been used for a long period of time, now 15 years. It's now off patent period. And a lot of biosimilars have come for ranibizumab now, which are Indian and which are available. So ranibizumab and its biosimilars are there. So around 7 or 8 biosimilars are out. Then comes aflibercept, and aflibercept in AMD as well as diabetic macular edema on a general note works a little better than ranibizumab, but it comes with that expense, and actually aflibercept is also bringing in, it is also coming, a lot of biosimilars are coming in, they are on the pipeline. Probably in the next 5 years, we will see some aflibercept biosimilars as well. Brolucizumab is the newest kid on the block, and its molar concentration is 12 times higher than the other things, so that the efficacy as well as duration of brolucizumab is longer and better. So, but brolucizumab is now currently indicated, currently licensed only for use in AMD. We are not using it in DME or any other conditions. Then the steroids, we have intravitreal triamcinolone acetonide as well as Ozurdex. These are the two steroids. And then the lasers. So that's a brief armamentarium that we have. Now I would invite Dr. Dinesh Talwar to have two key talks back to back. One is how to individualize and personalize treatment for AMD, and number two is DME. Over to you, sir. We look forward from hearing from you and learning from you.
Good morning, ladies and gentlemen. This is my disclaimer and my financial disclosure. Now, when we come to management of exudative ARMD, and now we are specifically talking of subfoveal and juxtafoveal lesion. I'm not talking of extrafoveal treatment, extrafoveal lesions. It's still not one disease actually, though there's been a tendency to put them in the same bracket, but you have predominantly classic, minimally classic, occult, and PCVs, which all can behave differently. More important than that, now, when we talk of anti-VEGFs working, we have the proof of concept came from the Marina and Anchor study, which showed that monthly treatment could result in a huge improvement in patients' visual outcomes. And that's for the first time in our lifetime that we saw patients of exudative ARMD improving. But the problem is this is an extremely intensive regimen, and it's extremely exhausting for both the patient and the doctor. The SUSTAIN study showed us that actually there is a wide variation in the need for injections. So the need for personalization comes from the fact that different patients need different number of injections over the whole year, and can vary from 3 injections to as much as 8 to 9 injections per year, and even more. The options available to us, as Gopal just told you, ranibizumab, bevacizumab, aflibercept, and brolucizumab, and their biosimilars. The treatment protocols, while monthly, 2 monthly, quarterly, fixed, PRN, treat and extend, have all been used, but the most important are the PRN and the treat and extend. Now, what is the optimal anti-VEGF for a patient? The optimal treatment is something which is efficacious, safe, easy to use, and has increased intervals between treatments. So this is what we are trying to achieve. From the responder profiles, what we see, this is from the EXCITE study, we found that there are actually three major groups. There is a group of patients which can be treated by quarterly treatments, and this includes the 20% who actually didn't need any treatment. So remember, when the 42% who were okay on quarterly included half the patients who actually needed no treatment at all. So keep that in mind. Another 34% of patients you found that they used to respond to the anti-VEGF, but quarterly was inadequate. And the last group is patients who don't seem to respond and who can only be maintained with anti-VEGF agents. The lessons we learned from the Pronto, Sailor and Sustain study regarding PRN treatment was that you need monthly follow-ups for these patients. Merely changing from 3 monthly to monthly follow-ups is enough to improve the visual prognosis and the visual outcomes. Stringent guidelines are needed for retreatment. So what are these stringent guidelines? Any loss of BCVA, 5 letters or more, is enough to treat. Any macular new fluid or persistent fluid since the last injection is an indication for considering treatment. Any increase in CRT is an indication for treatment. And most importantly, only OCT alone is not enough. You need to look carefully at the fundus, because any new macular hemorrhage, even if the other things are not showing anything, but you see a small hemorrhage which is new, is an indication for treatment. And finally, if the surgeon says, hey, this is something not quite okay, I think there's something more fluid has increased from before, even if objectively it cannot be documented, the surgeon's subjective evidence is enough to justify another treatment. In the treat and extend protocol, on the other hand, you give injections till the exudation stops, and then you keep on increasing the duration between injections by two weeks. Or some do it 4 weeks also. And if there's a recurrence, you go back. If the recurrence is severe, you can even go back to monthly treatment and restart the whole procedure. And if there is stable fluid, some people don't extend the treatment, but some people even decrease the interval between treatments. Now the important thing here is that you're trying to decrease the number of injections required to stabilize the eye. The Altair study, which is a recent study on aflibercept, actually would shorten the interval if there was persistent fluid also. Not increasing, but just persistent. And in increasing fluid, of course, it would shorten. It would maintain the interval if the fluid was decreasing. And so that means a very intensive treatment, and extend the interval only if the lesion was dry. In my opinion, a treat and extend, in this country, a treat and extend regimen is possibly, which is a very proactive regimen, is probably the best option for patients who are stable and not dry. For patients who are dry, it's probably better to use a form of PRN called the wait and extend. That means it's dry, you keep on following up regularly, but treat only when needed, and you can increase the intervals between these injections, between these follow-ups. Which drug is optimal? Now, if you talk about safety, both ranibizumab and aflibercept are safe. Bevacizumab, the only issue we've had are episodes of cluster endophthalmitis, which has actually scared me completely. Maybe I'm more of a scaredy cat. So, with brolucizumab, there is a risk of 1 in 200 of intraocular inflammation, and a risk of 1 in 400 of inflammatory vascular occlusions. Some of them will recover, some will not. Systemically, if the patient has a recent MI or a recent stroke, the only safe drug which has evidence is based on the Sailor trial, ranibizumab 0.3 milligrams. So that, nobody can catch you that why did you give 0.3 milligrams? It has no effect on the systemic safety. Now, what about the duration that you can maintain? Well, the fluid study showed that with ranibizumab, more or less, you could get an average extension of 7 weeks. The Altair study showed us that you could get an extension of up to 12 weeks in up to 60% of patients, and up to 40% in of extension for 16 weeks in 40% of patients. So 40% of patients can actually end up with 16 weeks intervals. The Hawk and Harrier did not go beyond 12 weeks and showed that brolucizumab could be used 12 weekly in a large number of patients. How do I approach my individual patient and how do I individualize the treatment? It is not individualized based on a particular biomarker. It is based on the response to treatment. So you give the initial 3 injections, assess at month 3 if the lesion is dry. Now you have 2 options. You can either go to treat and extend with increasing intervals as long as it stays dry, or you can go into a PRN mode and treat whenever the patient gets an activity. So this is just to show you the same in more detail. If you have a dry lesion, you watch for the next 3 months, patient is dry, you now increase the intervals between the treatments from 4 weeks to 6 weeks to 8 weeks up to 12 weeks if the patient remains dry. If a recurrence occurs, you treat the patient with an injection as and when required and then follow up again the same 4 weekly. In a one-eyed patient where you don't want to take any risk at all and you don't want to, you want to be absolutely safe, you may decide to use a treat and extend regime because you will be treating proactively, not letting it become the recurrence come. This is, I'm talking about in our country, I would advise this only for one-eyed individuals, but yes, a patient can afford it, he says, I want it, you can think about it. This loading dose can be with ranibizumab or it could be with aflibercept. Personally, I believe that aflibercept is a stronger drug but also has a higher tendency to cause geographic atrophy for the long term, the basis of which if somebody brings up in discussion, we will talk, otherwise we will not. The patients who are not dry at 3 months, now they have some fluid, now you continue monthly injections and you find that they become dry. If they become dry, you have the algorithm for that already, go by that. If they don't become dry, now you see, have you reached a stage where you have after 2 consecutive injections, that means 3 consecutive OCTs, no change in the OCT, no change in the vision. That means absolutely stable. This is the situation where you can now put the patient on a treat and extend regime and see how much can you extend. Can you extend to 6 weeks, 8 weeks, 10 weeks or 12 weeks? If you are on ranibizumab, you generally won't go beyond 12 weeks. If you are with aflibercept, you could try up to 16 weeks. Nowadays, we've started shifting to aflibercept as the initial drug of choice. Now, if you're doing initially aflibercept, and then if the patient does not become dry after 3 injections, this patient will have to go into a treat and extend regime directly. And when you put him on a treat and extend regime, unless you get an interval of more than 8 weeks on this treat and extend regime, it's not worth putting him on a treat and extend regime. You might as well go to ranibizumab. We'll come to that. Okay, so here we are, we've given 3 injections, the patient becomes dry. Now the patient becomes dry, I don't want to take chances. In this situation, specifically if I want to bring down the cost, I can shift to a treat and extend with ranibizumab. And if I feel that with ranibizumab my treat and extend regime can go beyond 6 weeks, I can continue with that and see how much is the maximum I can extend it, maybe up to 12 weeks, great. If I cannot do that, I go shift back to aflibercept and see what is the maximum extension I can now get. So I give treat and extend aflibercept, see can I go beyond 8 weeks, great. I put him on aflibercept. But supposing even with aflibercept I'm not getting this 8-week extension, that's the situation where you should consider a shift to brolucizumab, the new drug of the block. Because if both aflibercept and ranibizumab are going to be used 4 to 6 weekly, then I would prefer to use ranibizumab rather than aflibercept because it's a less, let's say it's a less aggressive form of therapy. Just to show you, if you have given the 3 injections of ranibizumab, still needing injections regularly, like in this patient, continued to require every 6-week injections, we put the patient on aflibercept, extended from 8 weeks to 10 weeks, it was maintained on 10 weeks, but on 12 weeks, we challenged him with a 12-week extension, he got a recurrence. And twice we did that. Once that happened, we went back, now we know this patient can
not go beyond 10 weeks, and he was being maintained on 10 weeks till he finally passed away. Now, this is another patient where we started with aflibercept, but after 3 injections, still we are needing injections 4 to 6 weekly, which was very disappointing because I was expecting wonderful results. That did not happen, and that can happen. So don't be very overly optimistic. There are patients who do not respond after 3 injections. These patients are then put on a treat and extend, and you maintain them on the maximum extension possible. And as I said, you can consider a shift to brolucizumab if that extension is not good enough for you. This patient was a 6-year follow-up. I'm not showing you the 6-year follow-up. Why I wanted to show this, you'll see he was on ranibizumab, got an extension on, got a recurrence on ranibizumab, shifted to Eylea. This is the second shift to Eylea. He started with ranibizumab, shifted to Eylea. Patient said, not working, go back to ranibizumab, went back to ranibizumab, got a recurrence, said, now put me back on Eylea. And now on Eylea, we got to 8 weeks, then came back to 6 weeks, and then came to 10 weeks, 16 weeks, and finally maintained him on 16 weeks. So we reached 16 weeks. Now why I'm telling you this, don't expect that because you've gone from 6 to 8 weeks and 10 weeks, the next has to be 16 weeks. It could be a regression. And then again you go back again. It's like, you know, Sisyphus taking the stone up the hill, goes up half the way, comes down, goes up the next time, comes back, and finally you will reach the top. In many cases, not every case. So don't lose heart if you have to regress. You will regress in some of them. But one thing, and we have a very august audience, panel over here, and I'm going to expect them to help me answer this question because I don't know the answer. This patient was on 16 weeks twice, and then came COVID. COVID has taught us a lot. It forced us to learn. The patient didn't come. For next 20 months, no injection was given. He's maintained. My question is it possible that if a person has maintained on 16 weeks twice, this is the biomarker for now saying, okay, no more, this is good enough? That the panel will answer. I will hope I get an answer from them. This is a patient who now was on Eylea month after month after month. Do you see any change in the OCT? Nothing's happening. But I didn't have a better drug. And then came brolucizumab. So I gave him brolucizumab, and looks like a wonder drug in this patient. And Srinivas always gets wonder responses, but I get sometimes. So here after 1 week, the RPED went off, the SRF went off, and then at 1 month it was gone. And so I did not want to, by that time there were results showing that if you give brolucizumab too frequently, the chances of complications goes up. So I didn't want to give it at monthly intervals. So after 1 month, I actually gave him an Eylea. And after I gave the Eylea, he decided to go to Bengaluru, and he's come back now, and he's got another injection recently. Now, this was a great response. This is the second patient. This had intraretinal cystic cavity. Again, same thing. She just refused to respond. This is months and months of injections being given. And so we decided to give brolucizumab, and you see over here, brolucizumab given. And 1 day post-op, nothing. 2 days post-op, nothing. 1 week post-op, nothing much. But 1 month post-op, you can see the cysts have become less. So there is a partial response. Again, I did not want to give the second injection at that time, so I gave aflibercept. And then again, despite the aflibercept, the cysts increased. So I gave another injection. This time, 1 week post-op, there was a response. She's also now, she went off to USA. So she came back, she's got another injection now. So this was a patient who got a partial response. So you have all sorts of response. I have a third patient whom I have not shown who got no response. So it's not that brolucizumab is the panacea for everything. We are talking of recalcitrant patients. Let's say some will do very well, some will get some response, and some will get no response. So this is what. Now, when to switch? This is important because ultimately, again, the decision to switch is based on therapeutics as a biomarker. I don't have a biomarker like saying, if you see this kind of cyst, treat. No, there isn't any such um, magic wand. But if the frequency of injections with ranibizumab is less than 7 weeks for a recurrence, switch to aflibercept. If the frequency with aflibercept is less than 7 weeks for a recurrence, shift to brolucizumab. If you are got a stable lesion which is not dry and you are on monthly ranibizumab, shift to aflibercept. And see, you can get a better response. If you have a stable but not dry lesion and 4 to 6 weekly aflibercept, that's not good enough, shift to brolucizumab. And if you are already on brolucizumab, then you don't want to have the patient without the treatment. I personally prefer, rather than having 3 months gap, which they say you can give the injection at 3 months intervals, I will intervene with aflibercept in the middle and shift between brolucizumab and aflibercept if there is persistent fluid at 4 weeks post injection. But something to now, this is last food for thought, because we've got, again, this august panel will help us to put this in perspective. So this is a long-term study of aflibercept, ranibizumab and bevacizumab. And you know what they found? No difference in visual outcomes or in the number of injections, regardless of the agent used. The OCT showed decreased fluid from the initial to final follow-up. All the drugs, no difference between the drugs. This in the long term, comparing all the work they had. Number of injections. The eyes that gained more than 2 lines, they got more injections. So basically, what happened? The eyes that got more injections, the eyes that were followed up with more time, the eyes which were treated on time, they were the eyes that gained. It did not matter whether it was aflibercept, ranibizumab or bevacizumab. And that is very heartening, because I get this question all the time. My patients can't afford aflibercept. Today the answer is, it doesn't matter. Give bevacizumab if the patient can't afford anything else, but let him get the treatment on time. More important than the number of than the injection type is the number of injections he gets, the frequency with which he gets them, which will be varying, and the getting the injection without having recurrences. That's the best. So this is what you need to do. And then this is a study in which they decided to give ranibizumab every 8 weeks or so, and at 7 years. This is not a small study, and this outcome is in blue, and it stands out from every other study that you have. Remember that. The only thing is, they had large number of injections, but they got the best results, better than 20/40 vision in half the patients at 7 years. There's nothing comparable available with us. So these results are possible, and for even this small group which is here, I can only urge you, don't give up on your patients. That's all that is important.
That's the most important message, sir.
Yes.
Don't give up, and long-term treatment, you have to counsel the patient in that way.
Yes. So this is what is important. The basic approach is, there is no tolerance for fluid. Intraretinal fluid is not tolerated unless it's completely unresponsive. I showed you. It's stable, not going. I'm still giving injection. I'm not stopping it. Subretinal fluid is again only tolerated if it is non-responsive. It does not mean I'll deliberately leave 100 micron fluid. Sub-RPE fluid does not go away with ranibizumab. It does not go away in many patients on aflibercept. It has better results with brolucizumab, but I don't run after sub-RPE fluid. It does not change visual outcomes. As of now, if somebody tells you, let's give brolucizumab because we'll make that RPE go away, that multi-layered RPE go away, somebody has something else he's talking about. He's not talking about medicine. So please do not go after that multi-layered RPD. It will not go away. But increase in fluid is not to be tolerated. Any increase in fluid must be treated.
Sir,
Last,
yeah, so we will,
it's last.
yeah.
This is last bit. Aggressive treatment is the way to go. Monthly treatment is essential till the lesion heals, and then 3 monthly lifelong. I've already told you the parameters to treat. Eternal vigil is the price that we pay for maintaining vision in patients with CNV. Thank you very much.
Thank you,
Sorry,
sir.
I've taken a lot
Thank you,
of
sir.
time.
We will do one thing, sir. We will have Srinivas. Srinivas has to go to another hall. So we'll have Srinivas talk on Srinivas Joshi, our veterinary surgeon from Hubli. He will speak to us on personalizing treatment for RVO before Dr. Dinesh Talwar completes his talk on diabetic macular edema next. So we'll give him a respite.
Good morning, everyone. At the outset, I would like to thank our Anna, Dr. Gopal Pillai. So he has been actually last time in one of his this thing. I think it's a post banquet session, first session. So we are seeing. Otherwise, most of the times we see his hall so full that the speaker only doesn't get chance to sneak into and go if he comes late. So I once again thank you, Dr. Gopal Pillai sir, and our esteemed co-instructors, Dr. Natasha, Dr. Darai sir, and our ever-loving Dr. DT sir. So I'll just to give a brief. We all know that it's a second most common cause. That's the after diabetic retinopathy. We have CRVO, BRVO, but recently TRVO, that is the tributary retinal vein occlusion, has been described. That is the involvement of the second or the smaller vessels as well. So with just tried for the sake of postgraduates sitting here, watching here, which includes hemodynamic changes, that is the venous stasis, degenerative changes of the vessel wall, and the blood hypercoagulability. So these three play an important role in the pathogenesis of it. So RVO, all we know, it's about 5 in 1,000 cases, but what important here is the BRVO is 5 times more than CRVO, and the incidence is more if they are more than 80 years of age. So there are various causes for the loss of vision: macular edema, hemorrhage, neovascular, NVG, ERM, or the tractional retinal detachment involving the macula. So again, the ocular and the systemic workup is very, very important. Complete history, physical, fluorescein angiography, and gonioscopy. We most oftenly try to miss it. The gonioscopy is very important to rule out any neovascularization at the angles, and of course a high magnification trying to look at the iris to rule out any NVI, but that is the signs to pick up so that we can stop them from going from non-ischemic to ischemic or various other complications. So again, complete blood workup, but I would like to suggest to make a tailor-made approach, not just to order all the investigations at once. So if the investigations initially are coming negative, then I suggest to go on more and more further. So the risk factor management, people have tried using anticoagulants, antiplatelets, and fibrinolytics. Theoretically, yes, these drugs should help, but they have shown very little or no benefit from their use in most of the studies. So hemodilution is another way, that is decreasing the blood viscosity to enhance the blood circulation, and studies have shown slight improvement, but they are all monocentric. So there are a lot of treatment options available. Either we can do lasers, the intravitreal injections, or the anti-VEGF injections. Surgical modality, I'll just come to it. But these are the common surgical modalities which we do in non-resolving vitreous hemorrhage, TRD, CRD, or ARM. So these are the other surgical modalities which are worth to remember, but they are now almost become obsolete. Is the radial optic neurotomy, chorioretinal venous anastomosis, TPA injection through the retinal vein, the arterovenous sheathotomy as shown in this picture here, and SOAF, that is super selective ophthalmic artery fibrinolytic therapy. So what are the prognostic values of the retinal vein occlusions? The more the HRF, that is hyperreflective foci, as you see in this picture, poorer the prognosis. But there is interesting paper which says that the better prognosis when the HRF is present in the outer layers, not in the inner layers. So the HRF in the inner layers are more to find a poor prognostic factor. Again, more the drill at the baseline, again the worse is the prognosis. And here you can see that is the thickening of the middle limiting membrane, which says the signs of acute ischemia, ischemic damage, and these are the patients who usually have a slightly worse visual acuity, and PAM if they are associated with paracentral acute middle maculopathy. Now you can see, even though there is no fluid here, even though there is no much of edema here, but these are the poor prognostic factors that's called as the OCT biomarkers in the case of the vein occlusions. Now coming to CRVO, there are various studies here. Apart from that, we have Horizon study, Retain, Shasta, Comrade, Crystal, Newton. So there are various studies which have been mentioned here. In non-ischemic CRV with no macular edema, we usually observe monthly for first 3 months and then later 3 monthly. And of course, we have to look in for signs of conversion to ischemic CRVO. So if the visual acuity is less than is around 6 by 90 or more than that, then anti-VEGF or the Ozurdex. Less than that, I would rather prefer Ozurdex, but many people prefer anti-VEGF also. But if the visual acuity is better than 612, then they can usually be observed, provided they are non-foveal involving edemas. So the choice of injection, again there is plethora of injections available now in the market. You have DEX implants also, usually better choice in patients with recent cardiovascular events and those who do not favor monthly injections. So switching to other anti-VEGFs, this is another study which switched ranibizumab in eyes, no responding to bevacizumab. So they found the significant improvements. Again, switching to aflibercept in eyes, not responding either to bevacizumab or ranibizumab, showed significant improvement anatomically compared to BCVA. So in non-responsive cases, the only methodology left with us is to switch these anti-VEGFs or switch from anti-VEGFs to steroids. In ischemic CRVO, and definitely anti-VEGF with early PRP, but if there is NVI or NVA with closed angle and normal IOP, then it's always better to add AGV along with anti-VEGF and later on PRP. But definitely if the pressure is very high, then we have to inject anti-VEGF, regress the vessels at the angle so that the IOP normalizes, and then plan for AGV followed by PRP. So in case of BRVO, again you can see lot of trials are available, BVOS, Bravo, Horizon, Retain, Comrade, Brighter, Vibrant, Marvel, Omar. So just to give a brief of that, if the visual acuity more than 612, then many of the studies or many authors would love to observe them monthly initially. But if it is worse, then anti-VEGF or steroid as and when required, and still no improvement, then we need to assess for the macular ischemia. And of course now OCTA is now the handy machine. If you don't have, then even fluorescein angiography we can try to recognize, looking for macular ischemia. But if the visual acuity is 6 by 12 or worse with macular edema, again the first choice is anti-VEGF, and if it is recurrent, then the choice goes shift towards the steroid implants. In ischemic, no macular edema, no neovascularization, FFA more than 5 disc diameters of CNP to observe. If there are macular edema, then go ahead with anti-VEGF. No macular edema, but however we find the neovascularization with or without associated vitreous hemorrhage, then these are the cases for sectoral PRP. So management of hemiretinal vein occlusion is almost as similar on signs of BRVO. These are last 3 cases. I would like to end my talk. In this case, you can see here, this is the sclerosed vessel with the vitreous hemorrhage. So the most important I would like to do is just to do a sectoral PRP and wait for the vitreous hemorrhage to resolve. If it's not, if it's complicating or if it's not going, or the patient complains of floaters, then only I would like to go in for PP, pars plana vitrectomy with endo laser in this patient. So this is another case of right eye ST BRVO with recurrent macular edema. So in these cases, I would rather prefer to use DEX implant because the monthly injections might be difficult. But however, the long-term injections, long-lasting injections like brolizumab hasn't got still approval for the use of retinal vein occlusion. But aflibercept is again a good alternative. But again, the economics also of the patients also have to be considered, especially for people like me who are practicing in tier 2 cities. So this is the another case. You can see here the pre-op, there is a vitreous hemorrhage. There is quite a lot of membranes here which is causing traction in the macula, and also there is vitreous hemorrhage. So I think these are the definite cases where just lasering will not help. In fact, lasering might cause more contraction, and even just doing the laser also might cause contraction. If you do the laser and leave it, it might cause contraction and worsen the traction over the macula. So this is the best way to go ahead is just do a pars plana vitrectomy, remove this fibrotic membranes, laser those areas wherever we find the ischemic or the sclerosed areas, vessels are seen under the under guarded visual prognosis. So in last case, so this is the BRVO with FEP extending towards the macula. I think these are the cases, if they have good vision, they can be observed. But if the vision is dropping I think these are the cases where you can see that the traction is already threatening the fovea or involving the fovea, and doing a vitrectomy and saving the further loss of this vision. That's how I explain to my patients that you might not benefit much from these. You might not get a good visual acuity, but definitely we try to save the existing vision. That is what is more important in this case. So this is the whole chart, what I was talking about. It contains most of these in the different arrows of the flow chart. And I would like to acknowledge our fellow Dr. Rajeshri Salvi and the Department of Vitreoretina at M.M. Joshi Eye Institute. Thank you very much once again.
Thank
sir.
you, Srinivas, for that very enlightening talk. So the basic difference between the AMD, as Dr. Dinesh Talwar is setting up his presentation, the basic difference is here, if your duration of, quiescence, if it is less, then you will immediately move to Ozurdex than from one anti-VEGF to the other, right?
Yeah. Sir?
So how many months of inactivity do you want post anti-VEGF injection for
first,
shifting towards Ozurdex?
yeah, of course, many of them try for 3 monthly injections, but I shift after second, or sometimes even after the first injection. If I don't see any response at all,
Then why
or
do you
there
want
is
to
a
give-
worsening, I have seen that in many of the cases where the cystoid spaces become tall, the SRF has increased, and I usually don't jump in for the second injection in those patients. But if subminimal response is there, I usually go in for the second dose. If no response even after the second dose, then I switch them to the Dex implant.
Thank you very much. Now over to Dr. Dinesh Talwar for continuing his talk on diabetic maculopathy. It is diabetic macular edema or diabetic retinopathy in all?
I left it at macular edema. It's the disclaimer. Now, in diabetic retinopathy, we have 3 treatment points: no retinopathy or early NPDR, medical management; maculopathy, active ocular management, in addition to the systemic treatment. Now, this is just to show you the lessons we have from the various studies which show that use of angiotensin receptor blockers, statin therapy, and fenofibrate can all help to um, control your patients with diabetic maculopathy. And this is the result of that maculopathy, which was shown to me by Dr. Vatsal Parak from Mumbai earlier. Now the question is, which anti-VEGF to use when, and when to change anti-VEGFs in diabetic maculopathy. The first basic principle: if the origin of leaks in a patient with DME is more than 750 micron from the foveal center, this patient is amenable to laser, and you should use focal macular laser preceded and followed by anti-VEGF treatment if required. But if the leaks are within 750 micron from the foveal center, then you use pharmacotherapy with anti-VEGF agents and steroids. Now, which drug to use? We've got the answer from the protocol T, and this showed that aflibercept was better than ranibizumab, which was better than bevacizumab, but the difference between aflibercept and ranibizumab narrowed in the second year. But more importantly, in patients who had good vision, better than 612, aflibercept, ranibizumab, and bevacizumab were equally good in terms of visual outcome. The difference was much more in patients who had poorer vision, where aflibercept stood out as compared to the other 2 drugs. Now, the important thing is that there is a group of patients, which is around 50% of the total, who with aflibercept 3 injections will improve by more than 10 letters. This is an elite group. This group of patients can be maintained on aflibercept with great results. There is another 25% of patients, which you see over here, which does not respond well to even aflibercept. This is the patient where you may consider steroids as an alternative. If you're using ranibizumab, the 50% which you saw on aflibercept comes down to 25% with the ranibizumab, but again with 3 injections they too respond very well, and these patients require just around 4 injections in the whole year. So if you have this group, just maintain on whichever anti-VEGF he's taking. But if you have, now, if you've got patients in the poorer baseline visual acuity, even those who had, in that group, aflibercept is definitely better than the other 2 drugs. But in patients who had very good vision, in those also,
Keep in mind, bevacizumab does not do as well as ranibizumab or aflibercept. Those two are similar. So if you have to give a choice to a patient who's got good visual acuity, better than 612, the choice is between aflibercept and ranibizumab. You can further subdivide. There are patients whose baseline thickness is more than 400 microns. This specific group does best with aflibercept. Patients who've got thickness of 250 to 399 micron, aflibercept and ranibizumab are equally good. And now, if your patient can't afford monotherapy with aflibercept, you can add laser to both bevacizumab and ranibizumab and get the same degree of drying in these patients who've got poor visual acuity. And this is what you see over here. The other important thing is that if you're giving anti-VEGF and the patient is slowly improving, you can expect the improvement to continue for up to six months. So don't give up. But if you find after 3 injections nothing's happening, this is the group where you should consider shifting to steroid. When you start your treatment, not in patients who've got good vision, better than N8 and better than 612. If a patient has 6/9 vision, N6 vision, think about yourself. Would you get an injection? No. Don't advise it to your patient. All it will mean is 8 injections in the ear and no advantage. And this is not my personal experience. On the protocol, we also showed the same. Intensive treatment with aflibercept was no better than observation in these good vision patients. But if the near vision gets decreased, nobody stresses on that. If the near vision gets affected, or if the distance vision gets affected, both are indications for starting treatment, which will continue from initiation with PRN, but you'll continue to give the injection monthly till the foveal contour normalizes and the vision becomes better than 612. That's when you're going to stop. If it doesn't reach that point, and if there's no change in status with 2 consecutive injections, consider steroids in these patients. I'm going to show you this study, which is very important and which is good for the panel to think about, because this shows that in treatment-naive patients, if you give combination therapy of an Ozurdex injection within the first 2 injections or so of ranibizumab and compare that with monotherapy, the results are hugely different. Patients in the combination group got 21 letter improvement. That's more than 3-line improvement. It's mind-boggling because you don't get this result in any other study, as compared to 9.6, which is the normal kind of response in monotherapy, with a huge improvement of more than 3 lines in 60% of the patients. So, if your patient has not improved after 3 intravitreal injections, adding an Ozurdex implant and continuing anti-VEGF after that is probably worth investigating. I don't have the answers yet, but this is something that anybody can think about. But the real thing now, the mindset we need to change. Can we make the clock turn back on the angiogenic process in diabetic retinopathy? And this is what is seen over here. With anti-VEGF treatment, you can actually cause a regression of the diabetic retinopathy. So in patients who have DME with NPDR, ranibizumab and aflibercept were equally effective in causing regression, whereas in patients who had PDR with DME, aflibercept was much better than ranibizumab, but even ranibizumab caused a regression of the diabetic retinopathy process in 50% of patients. So ladies and gentlemen, early intensive treatment with DME in the first year leads to sustained vision gains with a reduced treatment burden in the second and third year. So this is important. Fewer patients of aflibercept need rescue therapy. Most can be managed on monotherapy. In patients with a CST of more than 400 micron and a vision of less than 20 for 40, aflibercept is the drug of choice. On the other hand, if you have patients who cannot afford that, you have an alternative treatment with ranibizumab, and it's optimal for 25% of your patients, and those who do not respond to that can be added with dexamethasone implant. Patients whose vision is less than 612 and the thickness is moderate can be treated with ranibizumab with reasonably good results, and if that's not giving you the result, you can add focal macular laser to get the best results. Again, ranibizumab is also effective in regression of diabetic retinopathy. Ladies and gentlemen, with judicious use of anti-VEGF agents as part of a multi-pronged attack, both systemic and ocular, we can definitely help to preserve vision and improve vision function in patients with diabetic macular edema, possibly even indefinitely, unlike ARMD where over a long term patient's vision goes down and may even be able to reverse the diabetic retinopathy. Thank you very much, ladies and gentlemen. I hope this was quicker.
Thank you very much, sir, for this lucid. Yeah. So, to end in diabetic macular edema, the first 6 months can actually be given to good systemic control because it really doesn't matter so much. But only problem is some patients, if you say control the diabetes and come back, they will never come back, and they will come back 2 years down the line with significant loss of vision. So that is one thing that we need to look at. Number two, when you in the first year you need intense treatment, in the sense that we have to somehow reduce the fluid maximally. And one thing Dr. Dinesh Talwar told us was combination treatment with steroids as well as anti-VEGF with a magic increase. But I think we need to look at that paper again because that is only one person who has basically told that. In none of the other publications we have that, so we need to look at it.
The others are recalcitrant.
Yeah.
This is the only one.
Treatment naive. So the treatment naive Ozurdex results in diabetic macular edema was also 14 letters. So that was also quite impressive. But generally we reserve Ozurdex for only recalcitrant diabetic macular edema. So to end up, personalization is the key forward, which over each year we will get better. When more and more data gets accumulated, we will know Darius was talking to us about each of the individual biomarkers and how those biomarkers can be incorporated into what Dr. Dinesh Talwar told us right now about the fluid and the response is something that will come in the next few years. So in AMD, it's about treatment, and long preservation of vision with continued treatment. In RVO, the dramatization of response is significant, but the challenge there is to reduce the number of injections to 2 per year or 3 per year, or minimal as possible. In diabetic macular edema, treat like crazy in the first year so that there is a reversal of diabetic retinopathy, as well as somehow the number of injections will keep on reducing through the years. Thank you very much for coming in and being with us. Thank you very much.